I'm sure you too have been confronted by patients who panic because someone made the diagnosis of mitral valve prolapse. And then you perform echo, and all you see is maybe a mild form of prolapse at best with not even regurgitation or only mild regurgitation. Now, it's very difficult to reassure these patients that everything is okay. I think the major problem is that we are just too liberal with making the diagnosis. Mitral valve prolapse is a syndrome, actually, and there's many different features we will find in these patients. In this chapter, you will find out which features I mean and how we can make the diagnosis correctly and how we can assess the problem if there is a problem at all. The Oxford Dictionary defines a prolapse as a medical condition in which an organ has moved down out of its usual position. In the case of mitral valve prolapse, we're not talking about the entire valve which is displaced, but only parts of the valve, parts of the leaflet. This is such an example. You can see the mitral valve is actually at the place it should be, but parts of the leaflet are actually billowing into the left atrium. This is a typical so-called myxomatous mitral valve prolapse, but there are also other forms, such as the fibroelastic deficit and secondary mitral valve prolapse forms. First, I want to talk about the myxomatous mitral valve prolapse, which is also called floppy valve, morbus Barlow, or classic mitral valve prolapse. By the way, mitral valve prolapse also occurs in dogs, in particular in spaniels, and is the leading cause of death in the so-called King Charles Cavalier Spaniels. In spaniels, it's known to be a genetic disease, and there probably seems to be a genetic association also in humans. It has a prevalence of approximately 2 to 3%. Females are more frequently affected than males. It's a progressive disease, and the mitral valve prolapse can appear at all ages, very often in the young and in the middle age. In the myxomatous type of mitral valve prolapse, we have a rapid multiplication of cells. This leads to marked thickening of the mitral valve, which looks different than the thickening we have, for example, in sclerosis or fibrosis. It is not as echogenic, it appears more soft. It's not only the valve which is affected, but also the subvalvular apparatus, and we have excessive tissue, which leads to billowing of the valve. Another typical feature is the rocking motion of the annulus. During systole, we have kind of a bending motion of the mitral valve on the annulus, and this correlates with the mid-systolic click, which you hear in the patients. Very often we only see segmental involvement. Only parts of the mitral valve are thickened, and only parts of the mitral valve show prolapse. Very frequently, however, it is the middle posterior scallop which is involved. How do we actually make the diagnosis of mitral valve prolapse? Well, certain measurement criteria have been proposed as to how much the valve has to prolapse into the left atrium to make the definition of a mitral valve prolapse. But those are very unreliable simply because there's always segmental involvement, and it depends very strongly where you use your cut plane or where you measure the prolapse. So in reality, it's more a visual assessment kind of a diagnosis, and a diagnosis where you not only incorporate the amount of prolapse or the presence of prolapse, but also the thickening of the valve and the rocking motion. Remember, it's a syndrome. There are more findings aside from the mitral valve prolapse. Also look for those to make the diagnosis. In this demo, I'll show you how to assess a patient with a myxomatous mitral valve. Also take a look at my eyelids. They also seem to prolapse. Why? Well, I was on call the night before, but I know that's what they all say. So this is a patient with mitral valve prolapse. Let's first look at the patient in a parasternal long axis view. And if we look at the valve, we can see that the valve is definitely thickened. We have thickening not only of the valve, but also of the subvalvular apparatus. You can see that nicely here. And if we look at the texture of the mitral valve, we can see that it is a more soft appearance, not very echogenic as you would find it in sclerosis or calcification, even though there are certain areas on the valve which do show degenerative changes. Here on the papillary muscle, and here in the posterior ring of the mitral valve as well. Now,
the valve does not show very much of prolapse, but nevertheless, if we look at the thickening of the valve and the motion of the valve, this definitely has myxomatous appearance. We can move the transducer towards the posterior ring and towards the anterior ring, and thereby we get a very good feeling for the extent of the prolapse. And we can also look at that in a short axis. Here in the short axis view, the mitral valve is definitely also thickened, and it appears as if both leaflets are thickened. Now let's take a look at the same patient through an apical view. Again, we find the mitral valve thickened, myxomatous. Let's see if I can get a better view of the mitral valve. She has a few ectopic beats. And we can scan the entire valve by going towards the coronary sinus view and then back towards the 4-chamber view and then to the 5-chamber view to look at all aspects of the mitral valve.
This image is more of historical interest. It shows the M mode of a patient with mitral valve prolapse, and while this was used in former days to make the diagnosis, it is of little help actually presently with the advent of 2D imaging. The only thing you can use it for is you can define in which phase of systole maybe the prolapse occurs. You can see here the billowing of the valve and the prolapse which occurs more towards the mid to end systolic phase. Briefly, I want to go back to the cause of mitral valve prolapse. Remember, we said that in dogs it's a genetic disease. Well, it's not much different in humans. There are familial types of myxomatous mitral valves, idiopathic and secondary forms, which are also often associated with some genetic defect. We see secondary forms in Marfan disease, Ehlers-Danlos disease, and pseudoxanthoma elastica, so disorders which affect the connective tissues. Slightly different from the myxomatous type of mitral valve prolapse is the so-called fibroelastic deficiency. Here's such an example, and what you can appreciate is that the valve is also thickened, but it appears more dense. In histology, the mitral valve also appears to have a different composition. Usually it involves the posterior leaflet, and in this case we also see that the posterior leaflet is ruptured. In other words, we have a flail leaflet. The last form of mitral valve prolapse I would like to discuss is the so-called secondary mitral valve prolapse. In this case, the structure of the mitral valve is completely normal. All we have is a compressed annulus. Thereby, tissue prolapses into the left atrium simply because the valve is now too large for the orifice. There are several reasons why we have compression of the mitral valve annulus. For example, in this case, we have pulmonary hypertension with a small left ventricle and also pericardial effusion. You can also see such forms of prolapse, for example, in hypertrophic cardiomyopathy. Usually, this form of prolapse, however, is not related to severe or significant mitral regurgitation. So, this very rarely presents some sort of problem. Severe forms of mitral valve prolapse, in particular the myxomatous type of mitral valve prolapse, very rarely presents a problem in the diagnosis. However, mild forms and subtle forms are often very difficult to distinguish from normal valves. Why? Because the normal valve has a saddle shape. It's not planar. And in particular, you have to be very careful when you assess the mitral valve in a 4-chamber view, because that's where you have the effect of the saddle shape most. Also look at it in the 3-chamber view and also in a peristernal long axis view. So I personally don't believe that measurements are very helpful, and that other findings are more important. Even in subtle forms, you will usually find some other typical feature of myxomatous mitral valves. So what do I tell a patient if I find a mitral valve prolapse? Well, it depends very much on how severe the prolapse is. If it's a very mild form of prolapse, I just tell them, well, It's okay. He does not need to worry, but he should come back maybe in 5 years, 6 years or so. If it's a prolapse where there is really a myxomatous valve and where there is some degree of regurgitation, I do ask him to come back maybe in a year or two. Then I can kind of get a feeling for how quickly we have progression of the disease. But still, I reassure him that everything is okay and he does not need to worry.